You're listening to the recorded lecture on management of patients with musculoskeletal trauma. By the end of this chapter, you should be able to differentiate between contusions, strains, sprains, dislocations, and subluxations, identify signs and symptoms of an acute fracture, describe common treatment modalities for fracture reduction, fracture immobilization, and management of open and intra-articular fractures, discuss the prevention and management of immediate and delayed complications of fractures, apply the nursing process as a framework for care of a patient with an amputation, and use the nursing process as a framework for care of a patient with a hip fracture. The fourth leading cause of death is unintentional injury. Fractures occur or account for more than 1 million hospital discharges, and treatment is guided by severity of injury, and it focuses on the following. Using the acronym PRICE, you want to protect from further injury. You want to rest the area that was injured, apply ice for the first 24 to 72 hours. And when you apply ice, you're going to do it for no more than 15 to 20 minutes at one time. Otherwise, you have rebound phenomenon. C is compression. So you want to apply pressure or compression therapy. This will control the bleeding. It will also help with edema, and it will stabilize, which will help with discomfort. And then you want to elevate the area, if possible, just above the heart level, and this will also help to control the swelling. Pain management, you can give, as long as it's not contraindicated, NSAIDs, and that's going to help with both the pain and the inflammation. And you're going to want to make sure that you do good neurovascular checks. You're going to check the patient every 15 minutes for the first 1 to 2 hours after the injury, and then every 30 minutes until the patient is deemed stable. And that's because what you're checking for is to make sure that they can move whatever's affected, the area below that. So if they hurt their leg, can they wiggle their toes? Can they feel their toes? Do you have a pulse in their toes? Are they complaining of tingling sensation or numbness? Do you see any discoloration or pallor, which can be a sign of decreased or no circulation? You can check for a cap refill. Difference between dislocation and subluxation. A dislocation is a full articular surfaces of the joints are just completely not in contact. So it's a full separation in that joint. Subluxation is just a partial dislocation. And then you guys can read the definitions. They're there. You need to know the stuff on the slides, but I'm not going to read it to you. Okay. There are different types of fractures. Simple fracture, no break in the skin, one fractured area. Compound fractures involve damage to the skin or mucous membranes as well as bone, and that's why it's called compound, because it involves more than one. And a compound fracture can also be called an open fracture, so you'll hear both of those used. Compound fractures are graded 1, 2, and 3, depending on the amount of damage to the soft tissue and the surrounding tissue and skin, as well as the bone. Okay. And then you can have an intra-articular fracture. You can have a fracture actually in the joint itself, and it can extend to the joint surface of the bone. And we talk about hip fractures a lot whenever we talk about those types of fractures. Okay. Compression fractures involves a compression of the bone. It's seen in vertebral fractures. Impacted fractures occur when a bone fragment is driven into another bone fragment, and that's that impact, that's where they get that name from. Transverse fracture occurs straight across the bone shaft. And one more I wanted to bring up is the spiral fracture, because this is where the bone or the extremity where the bone is located is actually twisted. And so you have this twisting of the bone and fracturing that way. It's seen a lot in abuse children. So that's why we always look at spiral fractures. As far as how the patient will present, they'll have continuous pain in the area that was injured, and then the immediate area can become numb. You can have spasms, muscle spasms in the surrounding tissue, which can increase pain. If it is a long bone that's fractured, you'll actually see shortening of the extremity. So if your right leg bone was fractured, then you'll actually see a noticeable difference in the right and left leg. Same thing if you have a fractured hip, you'll see a noticeable difference in the two extremities. You can also see crepitus or feel or hear it, and it's a crumbling sensation with gentle palpation, and you can feel and you can hear it. Once you feel it, it's kind of eerie, but you're actually feeling crumbling of some of that bone or the bone fragment. Neurovascular check, again, your 5 Ps. Do they have sensation? So is there pain if you were to poke them with the tip of a pin? Do they have good pulses? And you want to start with the distalmost pulses from the affected area. Do you notice any pallor? Is their skin white? Or is it appropriate for their ethnicity, or is it grayish if they're darker complected? Okay. Do they have paresthesia? So can they feel or not feel? Is the area numb? And then are they able to move their toes, their foot, whatever it is, fingers if it's an upper extremity? Or do you notice paralysis? Those are things you want to get the physician and notify him immediately of any changes for anything that has been fractured. As far as emergency management, immobilize the body part that was injured. You can do this by splinting. So you can grab something to splint the extremity. You can use the left leg if the right leg is the one that's injured, and you can actually splint one leg to the other one. Basically, you're wanting to immobilize so that you can prevent any further damage. Upper extremities can be splinted. They can also be secured to the chest if you don't have anything really to splint the extremity, but you can secure it to the chest with a shirt or a scarf if you have a scarf, just anything that you can get to secure that so that you don't have any further damage. You're going to do a neurovascular assessment before and after splinting just to make sure that you're not causing any further damage. If you do have an open wound, you want to cover it as quickly as possible with a sterile dressing if you have a sterile dressing or the cleanest thing that you have. And that's so that you don't get any further debris in it and to try and protect it as much as you can. If you are out and about, do not attempt to reduce a fracture and realign. Just immobilize by splinting, cover if it's an open wound, and get them to the ER as soon as possible. As far as medical management, the specific method of reduction of the fracture will depend on the nature of the fracture. You want the realignment to occur or the reduction to occur as soon as possible after injury. As the bone starts to heal, and it will try to heal quickly. It depends on their nutrition and age and other things, but the body does want to try and heal itself as quickly as possible. When the bone begins to heal and calcify, you can have difficult realignment or even misalignment because the calcification is occurring in places it shouldn't. You can have 2 types of reduction. You can have a closed reduction, and that's just manual manipulation of the joint followed by a cast or splint to immobilize the area. So they'll do an x-ray, see if they can do manual manipulation without surgical intervention just to immobilize the area. And then once the cast or splint is put on, they'll do another x-ray to make sure the alignment's still there. They can also do open reduction internal fixation, ORIF. And that is whenever they surgically go in and realign the fractured areas. And then they can use pins, wires, plates, screws, whatever they need to keep the bone fragments aligned until they're able to heal. As far as nursing interventions, pain control is going to be a huge deal. You can apply ice, elevate, provide them with reassurance, especially if they're worried about, with limited mobility, will they be able to work still? Will they be able to drive? Will they be able to fulfill their obligations that they need to fulfill? Um, they can perform isometric exercises as long as it's not contraindicated, and that promotes circulation and minimizes atrophy in the affected limb. They need education on any limitations. If there's cast care or splinting care, then they need education on that. You never stick anything sharp under the cast, and they will have itching and they'll want to do that. So no coat hangers under that cast to scratch, because they can cause wounds, and there's no real good way to look for wounds until they become infected and they start oozing. Any restrictions, they need to know if they have a lower extremity pelvic fracture, they're going to have restrictions on weight bearing and how they can sit, how long they can sit. If it's a vertebral fracture, then they're going to have restrictions as well. If they're given an assistive device, they'll need to make sure that they know how to use it safely. And anything that they might need to do in their home to keep their environment safe, you'll need to discuss that with them as well. So if they have rugs, if they have clutter on the floors, anything that can cause them to trip, or if they have an assistive device, get the assistive device caught up in it, it needs to be removed. They also need to be aware of self-care. If they have casting, it's going to have to be covered before they can get in the shower. If they have a type of cast that they can get wet, then they'll need to be taught how to keep it dry and clean as much as possible after their shower, so that they don't get the maceration of that tissue underneath the cast. They'll need to be educated on medications, especially if they're opioid-based medications. Potential complications that they'll have to report immediately. They'll need to do follow-up visits, follow-up care, and then what to expect longer term. How long will it take to heal? Best case scenario, worst case scenario. The doctor should go over all of this with them, but they're going to need a lot of reinforcement on their education. Okay. If they do have an open fracture, or if they did have to have an open reduction, then the biggest concerns are infection. So you want to prevent infection. Open fractures, they'll be given IV antibiotics immediately, and that's just because they'll have debris in their fractured area, foreign bodies that can cause infection. So they'll give them antibiotics IV. If they are not up to date on their tetanus toxoid, then they'll get that IM. And they'll go to the OR for surgery. While they're in there, they'll irrigate the wound to see if they can get rid of as much of that extra debris as possible. If they have to do debridement before they can do the reduction and close the wound, they'll do that as well. And then they'll most likely be on IV antibiotics after the surgery, just to prevent the infection. Factors that can affect fracture healing. A lot of different things can affect healing, and just think about any other acute injury or illness that a patient might have. There are multiple things that will affect how they heal and how they progress. Keep in mind, fractures of flat bones will heal more quickly. Complex comminuted fractures heal more slowly than a simple fracture. Fractures at the end of long bones will heal more quickly than fractures at the midshaft, and that's because they have more blood going to them. Excuse me. Fractures in younger patients will heal more quickly than fractures in older patients. If patients are on corticosteroids, then it will take longer for their bones to heal. If they're diabetic, then it can take longer for their bones to heal. If they have any type of rheumatic disorder, it can take longer for their bones to heal, especially if they have a joint that is fractured or an area around a joint that has fractured. Then that will take longer for them to heal. Complications, hypovolemic shock can occur, and that generally is from hemorrhage or just extensive loss of blood with a traumatic injury. It's more common in trauma patients with pelvic fractures, and then in patients with displaced open femoral fractures. And that's because the bony fragments can tear the femoral artery. Treatment for hypovolemic shock, you want to stabilize the fracture, restore blood volume, in circulation, control their pain, immobilize the area, and protect from any further complications. Fat embolism syndrome occurs most frequently in young adults. It can occur in elderly clients as well if they experience fractures of the proximal femur. So if they have a hip fracture, then they can actually fracture that proximal femur or socket. Fat emboli patients will present with hypoxia, tachypnea, tachycardia, and pyrexia. Respiratory distress is definitely acute. It's usually sudden onset, and the patients just get extremely anxious because they cannot breathe. They can't take in a deep breath. They feel like they're suffocating. So they'll have the precordial chest pain. You'll hear wheezing. They'll definitely have dyspnea, tachypnea. They'll have a cough, and it will be productive cough. They'll have large amounts of thick white sputum, can be frothy. They'll also be tachycardic. And treatment, supportive early fixation will help minimize them having a fat embolism. And if you have to have manipulation of the fracture, as minimal as possible, because the fat emboli occurs during the trauma. A piece of that fat becomes dislodged, gets into the bloodstream, and works its way up into the lungs. You need to make sure you have adequate support for fractured bones during turning and repositioning, and keep fluid and electrolyte balance to reduce the chance of complications. Compartment syndrome generally happens if you have a large bone injury. It's characterized by elevation of pressure within the anatomic compartment above normal perfusion pressure. It comes about from an increase in compartment volume. So you have increased edema from either fluid displacement or from bleeding. And it can also occur if you have a decrease in compartment size. So let's say they put a cast on and you're trying to swell, or the cast is too small. It actually reduces the compartment size, and that causes increased pressure. The increased pressure leads to decreased perfusion, and that causes cell death. And then the tissue starts to become necrotic. It occurs more frequently in young adults. It can take up to 48 hours to present. It develops fairly quickly, and the patient will complain of this deep, throbbing, unrelenting pain. No matter how much medication you're giving them, it does not help. Compartment syndrome is an emergency because it does cause cell death. And so the doctor can do a fasciotomy, where they actually go in and split the area that's affected into the fascia, and that will help relieve some of that pressure. The nurse needs to call the surgeon immediately. They will go immediately to the OR. The nurse can also bivalve the cast to relieve the pressure if the physician is not able to do it right away. So if you have a patient who has a cast, you should have cast splitters so that you can bivalve the cast and relieve some of that pressure, but they will need to go to the OR. Avascular necrosis, that's whenever the bone loses blood supply and then the bone itself will start to die. It's seen in patients who have rheumatoid arthritis, especially if they have trauma and they have that diagnosis. Can also be seen in patients with radiation therapy, if they have high-dose corticosteroid therapy, or sickle cell disease. The patient will complain of pain with movement, and it will progress to pain at rest. So pain that was controlled is now no longer controlled, and it starts whenever they move and then will be there all the time. Different than compartment syndrome, where their pain is sudden and severe, unrelenting, and continuous the whole way. Treatment for avascular necrosis, that you can give them NSAIDs. They can do exercises, limited weight bearing on the affected region, because if you have weight bearing to the affected region, you can cut off circulation or decreased circulation. Total joint replacement is done when it's in the hip or knee, so you just get rid of the diseased part. Complex regional pain syndrome is rare, but it's characterized by chronic pain after an injury of which the pain should have resolved with healing. So the healing's taking place. There is no more injury, but the patient is still complaining of pain. Women are affected more than men. Patients usually present with severe burning pain, local edema, hyperesthesia, stiffness, discoloration of the area, vasomotor skin changes, and treatment would be effective pain relief, rehab, and then a referral to mental health. These patients who have the regional pain syndrome have a lot of anxiety and become depressed easily. And that's just anyone who has chronic pain disorders. So they should have a referral to mental health to help deal with the anxiety and depression. Okay. Other possible complications, hemorrhage. So make sure that you're watching, especially if they had surgery, for any kind of internal bleeding or outright hemorrhage where you see the blood exit the body. Peripheral neurovascular dysfunction, you're going to do your neuro checks. Do those 5 Ps to make sure that there isn't any damage or potential for damage because it can be permanent. DVTs, you want to make sure that they're up and moving as early as possible. They can do the isometric exercises to help with circulation so that they don't get any kind of thrombus formation. Make sure they're doing their coughing and deep breathing. They're using their incentive spirometer so they don't get atelectasis or pneumonia. And then you want to assess for pressure ulcers. As far as nursing process, we want to make sure that we can control their pain. Make sure that they can get up and move, they have a stable site, that they have good wound healing, and that will include increasing their protein intake. Make sure that they don't have any issues with voiding or having bowel movements, and that they don't have any type of complications. For patients who have fractures, you can give them analgesics as long as they're prescribed, and you can give them as they are prescribed. You can't increase the dose if your patient needs the dose increased without contacting the physician. You can use buck traction, and that will help to stabilize the area. You want to make sure that you handle the affected extremity gently. Don't be rough with it because that can cause more damage. It can also increase their pain. Support the extremities with pillows whenever you're moving them. If it's an upper extremity, they can also support their own extremity. Make sure that you position them in a way that's comfortable, and they need to be repositioned at least every 2 hours. They should do their own little position changes by themselves whenever they're sitting or they're in bed as much as they can. And then talk to them about non-pharmacological measures to relieve their pain. If you have a patient who has a hip fracture, they have to have a neutral position of the hip. You can't have abduction or adduction. Whenever you're moving them, you want to place a pillow between their legs if they don't have any type of adduction pillow. Sometimes they have those, but sometimes they don't. So you'll always put a pillow between their legs, and you'll support their legs so that that hip doesn't pop out of joint. Again, they can still do isometric exercises. They cannot bend more than 90 degrees at their waist or their hip area because they can pop that hip out of place. They will have an assistive device. Generally, they start with a walker, and that's to help offset weight-bearing status and to keep them stable. They will get physical therapy. They might get occupational therapy as well. They cannot bend over to put on their shoes and socks or put their pants on. So they'll have to have a lot of different assistive devices that can help with that. You can use trochanter rolls on the outside of the hip and thigh, and that's so that the leg doesn't roll out. As far as health promotion, if you have an older adult who has a hip fracture, teach them about weight-bearing exercises. Make sure that they have a healthy diet. Their calories need to count, and they need to take in protein because that protein is going to help that tissue to heal. You need to talk to them about fall prevention, especially if they fell and that's why they have the hip fracture. So what caused it to begin with? Is there anything that you can do to make sure it doesn't happen again? They can get bone density testing if it was something that they can't identify how they fractured their hip, or it wasn't anything that was significant enough to where it should have caused a fracture. They should do ankle exercises. I always tell them write the alphabet with your toes because it helps promote circulation and decrease the chance of them getting a DVT. Again, coughing and deep breathing, incident spirometry. Have them do as much as they possibly can, even if it takes a little bit longer. It's better to promote self-care than it is for you to do it and them not to do it, because that gets them moving, it gets their circulation going, and it helps them psychologically with the loss of independence that they're going to have. Sports-related injuries do happen. Those that are involved in the injury are usually highly motivated to return to previous level of activity. They are also at risk for re-injury, and so you want to talk to them about prevention. And prevention of re-injury if they already have an injury, but prevention of injury is the best and most ideal. They need to be instructed on the proper use of equipment, the proper types of shoes for running shoes, as well as how often to replace them, wrist guards for skaters because they tend to fall quite a bit, and they should be using a helmet. They should have different guards, different pads depending on what sport they're playing. They need to have effective training and conditioning specific for the sport that they are doing. They should have proper stretching before and after their activities. They need to be well hydrated and have proper nutrition. They will have increased caloric intake, should have increased caloric intake because they will be more active and require more energy. They'll have higher metabolism as well. As far as occupational related injuries, we don't ever want them, but they do occur. And most common are your sprains and strains. You can have cuts, lacerations, you can have fractures, but sprains, strains, and tears are going to be your most common. And depending on the occupation, some occupations will have a higher incidence of injuries than others. As far as education goes for your patients, prevention is the key. So proper body mechanics, proper stabilizing agents if you need it, and lift, don't bend at your hips, bend at your knees whenever you're lifting. You want to push as much as you can, and you want to get someone to help you if you can. You don't want to lift something up above your head. If you are going up on a ladder, make sure someone else is there to hold the ladder, that sort of thing. Amputation patients. The amputation is done at the distal most point that will heal successfully. When you have a patient who needs an amputation, and it's not an emergency situation to where the physician can discuss it with them, they will give them different options. So they will tell them what they feel is the best option for the patient, and then they'll give them a couple of other options. Minimal loss isn't always the best because there is a chance they would have to go back in and re-amputate because they just don't heal. But sometimes patients will take that chance and they don't take what the physician recommends. They take something that isn't as extensive in the hopes that they will heal. So it's, we can do this and this is a chance of successful healing, or we can do this and this is a chance. And so it's a conversation that occurs. If it's a traumatic event where they have to go in and do it, then there isn't as much of a conversation, obviously. The physician looks at circulation to the area, as well as what kind of function the patient will have afterwards. They put a prosthesis on as early as possible because they want to maximize function. They also want to make sure that the prosthetic device fits and fits well. You will be involved in stump fitting. I believe is going to be on the next slide. So this is the different places where they can do amputations. Well, maybe not. Okay, so they will do something called stump fitting, and this involves either a hard cast or a soft cast in different types of wrappings or a compression dressing, and it goes over the stump and it minimizes edema, helps to improve circulation, and also kind of molds that stump so that you can have a nice shape in order for that prosthetic device to fit and fit well. You will have to discuss with your patients coping strategies. Give them a lot of psychological support, especially if it's something that they were not prepared for. Maybe they had a workplace injury where something landed on their leg and they had their leg amputated, or they had part of their hand amputated because they were using some kind of a saw and they slipped. So it isn't always something that is planned. They will need a lot of psychological support. They might be angry, they might lash out, and they're not doing it at you particularly. They're just angry, and you're the one there that is there all the time because you're the nurse. And so that you're the one they're going to take it out on. Education, you need to educate them on safety. You need to educate them on proper stump care, as well as use of a prosthetic, a use of assistive devices. If they're not supposed to use the prosthetic without physical therapy, which is generally how it works initially, then they really need to abide by that, or they can get hurt. They can fall, sustain further injuries. We have had people that are non-compliant and they don't ask for help. They think they can do everything by themselves. They don't want to use their walker or their cane, and they get up to go to the bathroom, they fall, they hit that amputation site and pop that incision back open. They have to go back in for another surgery to close everything back up. And the trauma itself can cause more tissue damage and possibly need for more amputation. So if they really understand the issues and potential complications, they're more likely to be compliant. Okay. When you have someone who has an amputation, you're going to do neuroassessment. You're going to look at both the affected and unaffected extremity. You do the distalmost pulses. So with the amputated extremity, the distalmost pulse is probably not going to be the same as the unaffected extremity. Make sure that they're free of an infection since they did just have surgery. And you always want to make sure if you have a patient who has an amputation that they have a tourniquet at the bedside. If they do hemorrhage, then you can apply that tourniquet to the affected extremity and cut off that circulation so that they do not go into hypovolemic shock. Okay. We talked about that. Skin breakdown, make sure they're moving around, turn and reposition every 2 hours, and make sure they're getting adequate nutrition. That should help prevent skin breakdown or pressure ulcers. They can complain about phantom limb pain, and to them the pain is still real. And that is because of the way that the body is being irritated by the nerve endings at the distalmost area where the amputation took place, how that's being perceived up in the brain. Okay. You want to avoid joint contractures, and depending on where the amputation is, there are certain things you should and should not do as far as putting the extremity on pillows or not putting the extremity on pillows, and it's all dependent on where the amputation took place. Okay. Post-op hemorrhage definitely can occur, especially if they're up and moving around and they're hitting that amputated site on things. They can knock a suture loose and cause a hemorrhage pretty quickly. So again, tourniquet, apply that tourniquet, call, and they'll have to go to the OR. There's goals as far as your planning. Limb shaping, I knew it was here somewhere. So there's your residual limb shaping. Promote wound healing. They will have a surgical incision that does need to heal. Handle with care because it is going to be sore. They can have, again, the rigid cast dressing, a removable dressing. They can have an elastic dressing. They can have a stump shrinker, which if they have a lot of edema, that will actually shrink up the stump so that you can have it fit in the prosthetic device. Make sure you're controlling their pain and The limb shaper can also help with reducing contractures. Make sure you focus on psychosocial. If they would like to speak to someone, ask them, offer it to them. There are, again, different community resources that they can reach out to. They can get individual counseling, group counseling. They can go to different support groups. They can contact someone else that went through the same situation and can help them with coping. If they have an amputation, they might temporarily be wheelchair bound, and so they might need to have alterations done in their home. They're not going to be as independent as they were. So there's a lot that you have to look at, and it can affect the family dynamic as well. They will grieve. They will grieve the loss of a limb, just like we grieve the loss of a pet or a human or anything else, the loss of a job. They will have a grieving process that they will go through. Obviously, we want them to be as independent as possible, promote self-care, make sure that they're doing range of motion exercises, make sure they're getting out of bed as soon as possible. They can start physical therapy, occupational therapy shortly after their surgery, and they just need to get up and moving, and that's going to be the best thing for them.